Good morning. I'm Kanchimik from Mongolia. So I'm going to talk about today is about heart failure prevention. It's very controversial title, so I'm going to speak about more specified as possible. I'm going to speak more about obesity related HFpEF, how to prevent it. So, as we know, heart failure emerges as an important contributor to global morbidity and mortality in both men and women. Despite advancements in medical and device-based treatment, from the epidemiological perspectives and lifetime risk of developing heart failure is equal for both genders, like around 20%. So it is responsible for 35% of cardiovascular related death in women. So women represent about 25% of patients diagnosed with heart failure with reduced ejection fraction, and about half of those affected by heart failure with preserved ejection fraction. There are fundamental sex differences that leads to development disparities of heart failure subtypes in men and women. This includes sex differences in cardiac structure and function, influence of sex-related hormones, sex-specific gene expression, inflammation, as well as anthropometry, and heart failure-related specific risk condition and also comorbidities that cause a higher relative prevalence in HFpEF in women. For example, women have a smaller LV chamber and lower stroke volumes, and increases in LV stiffness with aging are more pronounced in women. Also, female and male heart respond differently to afterload stress, so women more often maintain ejection fraction and develop left ventricular hypertrophy and diastolic function, where men more likely to develop eccentric remodeling. And anti-inflammatory and antioxidant effect of the hormone on the endothelium lasts after menopause, and which can lead to the higher incidence of microvascular dysfunction in older women. So we will go on to the common risk factors and comorbidities. So traditional risk factors for heart failure affect women more than men, and there are significant differences based on sex. For example, diabetes increases with risk of heart failure, and the risk is higher for women than in men. Hypertension is most common risk factor for development heart failure for both and men and women, but the risk of women is slightly higher than men. And about obesity, it is more prevalent in women than in men. Association with heart failure risk is greater for women, and obese women are also more likely to develop heart failure with preserved ejection fraction. Regarding the smoking, the tobacco use is less prevalent in women, but if the woman smokes, the association of smoking with heart failure among women has been shown to be almost double the risk of men regarding heart failure. And when then there is women-specific risk factors like reproductive endocrine factors, pregnancy-related factors such as adverse pregnancy outcomes, and others like breast cancer, treatment-related cardiotoxicity, autoimmune disease, and psychological, socioeconomic status, and also the Takotsubo cardiomyopathy, and so on. So for women, there are several sex-specific risk factors, especially in reproductive endocrine. The early menopause is also early preterm menopause, early menarche, all associated with the risk of heart failure. So adverse pregnancy outcomes such as history of preeclampsia have nearly 80% more likely to develop heart failure than women without hypertension during pregnancy. So stress, anxiety, depression, like the social, psychosocial stress and adverse psychosocial circumstances have been linked to the worst cardiovascular outcomes, including heart failure. So let's talk about obesity and heart failure in women. So in generalized and central obesity has been associated with heart failure incidence in multiple studies. And the relationship between obesity and incident heart failure is related to hemodynamic and anatomic cardiac changes, hormonal and metabolic changes, inflammation, and comorbidities resulting from excess body fat. Obesity accounted for 14% of heart failure cases in women. And there is investigators from California University studied a relationship between obesity, postmenopausal age, and heart failure incidence. And over 4,000 postmenopausal women who attended this ARIC study were enrolled in the study and followed for 16 years. So this study results showed that attributable risk of a generalized and central obesity for heart failure incidence was greatest among women who experienced menopause at age of 55 years and more. So there was a significant interaction between BMI and waist circumference maintains of the healthy body weight interaction between with the heart failure risk and maintenance of the healthy body weight and waist circumferences may be protective against developing heart failure, particularly women among who experience late menopause, like more than 55 years old. And there is also other study compared with men and women with HFpEF. As we know, obesity is modifiable risk factor of heart failure. It can be controlled as primary prevention from heart failure. So obesity and hypertension accounted for 2/3 of the attributable risk for HFpEF in women. So in this recent study, which was enrolled 2,000 participants from 4 community-based cohorts and followed for 12 years, study results showed that non-obese men and women had similar risk of incidence of HFpEF, but obese women had a highest incidence of HFpEF, indicating obesity and associated cardiometabolic characteristics have a higher risk of HFpEF than HFrEF. For women, menopause is associated with increased abdominal and visceral obesity. So further abdominal and visceral obesity worsens associated cardiovascular risks. So in this Korean nationwide cohort study result showed that postmenopausal women compared with premature or early menopause, a woman aged more than 50 years at menopause has relatively lower risk of heart failure, which means early menopause compared with early menopause. The woman who had late menopause had a relatively lower risk of heart failure. Also, the risk of heart failure and atrial fibrillation intensifies as the age at menopause decreases, with a particularly strong association observed in young women with obesity. So because the inflammation and insulin resistance associated with obesity is believed to be strong cause of HFpEF, women HFpEF, the women display multiple differences in body composition and distribution of fat, specifically in menopause period, and that may be more relevant to, that's why they are more relevant to HFpEF. Visceral adipose tissue is adipose tissue that stores around the internal organ, and previous studies has shown to be that this kind of visceral adipose, this kind of adipose tissue is more harmful than fat stored in other part of the body. So this study is about sex-specific differences in visceral adipose tissue relation to HFpEF, and results showed that compared with control women, visceral adipose tissue area was 34% higher in women with HFpEF. So while this visceral adipose tissue area was not significantly different in men with or with while this visceral adipose tissue area was not significantly different in men with or without HFpEF. Also, this study described that exercise-induced elevation of pulmonary capillary wedge pressure was seen in excess visceral adipose tissue women, but not in men. So then participants divides into groups, two groups based on the presence or absence of increased visceral adipose tissue. And in women, the presence of high visceral adipose tissue was associated with 33% greater exercise pulmonary capillary wedge pressure as compared with women without excess visceral adipose tissue, whereas there is no difference in men with or without excess visceral adipose tissue, which means women display multiple differences in body distribution of fat, and that maybe this visceral adipose tissue is also relevant to the development of HFpEF. On the other hand, weight loss is very important for women in prevention of heart failure. Not only, not only visceral adipose tissue, also the peripheral fat volume using cardiac computer tomography in participant without pre-existing cardiovascular disease followed for a certain amount of time revealed that higher precardial fat volume is associated with twofold greater increase in heart failure in women. This is the concept in recently published international guidelines for sex-specific prevention of cardiovascular disease as well as heart failure. So as we can see, currently for heart failure prevention, we still don't have a sex-specific recommendation. But in 2024, just a few months ago, ESC and HFA had published scientific statement regarding women-specific heart failure management specific statement, but they didn't in that statement included the prevention management. So about the prevention, what should we do? So there is unfortunately no sex-related specific guidance for primary prevention for heart failure in women. Specifically maintain healthy weight. Treating hypertension is maybe most important for women, lowering incidence of HFpEF. However, it's recommended also to adapt general prevention activities such as maintaining the healthy diet and reduce coronary artery disease-related risk factors, smoking cessation, glucose control for diabetic patients. In terms of the visceral adipose tissue, as well as the precardial fat, there was a study mentioned about lactation is associated with lower risk for cardiovascular disease. Lactation could actually, the longer duration of lactation could reduce the visceral adipose tissue volume. And if the unsatisfactory response to obesity-related lifestyle intervention, there is unsatisfactory response, we can add new anti-diabetic drugs that have shown to be also have effect on visceral adipose tissue. And currently in the guideline, menopausal hormonal replacement therapies are not recommended for primary and secondary prevention of heart failure, as well as for the prevention of obesity. So in conclusion, women has different manifestations of cardiovascular disease, including heart failure. There are 6 differences in responses to risk factors, and women are more likely to experience HFpEF than men. Maintain healthy weight would be one of the most important contributor for reducing HFpEF risk, specifically at per or perimenopause stage. The generally from epidemiological and pathophysiological differences in the heart failure subtype strongly suggest that sex-specific preventive strategies and risk factor reduction may be particularly beneficial, yet major prevention as well as disease-specific guidelines. We did not still include sex-specific recommendations, so further in the future, deeper understanding of the sex differences and implement risk management strategies are crucial. Thank you very much.